So welcome to our fourth webinar. It's my pleasure to welcome Dr. Ashley Ross, a urologist, and Dr. Phuoc Tran, a radiation oncologist. Dr. Ross is Associate Professor of Urology at the Hopkins School of Medicine at Northwestern, where his research focus is on the development and testing and implementation of novel diagnostics and therapeutics for men with prostate cancer. Welcome, Dr. Ross.
Thank you.
Dr. Tran is Professor of Radiation Oncology and Molecular Radiation Sciences at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins, where his research focuses on the improvement of clinical radiotherapy for the treatment of prostate cancer. Welcome, Dr. Tran.
Thank you, Ryan. It's my pleasure.
My name is Ryan Dittema, and I'll be the host of this webinar. I'll provide an overview of Decipher and our genomic tests, and Dr. Ross and Dr. Tran will review the clinical data supporting therapy decisions utilizing genomics in newly diagnosed intermediate-risk prostate cancer. We'll then walk through patient cases each has managed and examine the use of Decipher tests in context to patients under their care and examine the role genomics had in the therapy decision. For the case review, we will plan on having an interactive poll of the audience to further examine the impact of genomics given the wide range of physicians attending this session. We may use this data in an aggregated, de-identified way for research purposes. By responding to the polls, you are consenting to us using your responses in this way. Speaking of polls, to start off this webinar, we have a couple short polls for you. The first is to get a better understanding of the specialty of the audience. So if we can go ahead and start the first poll. And so please click on that. And while we wait for those polls in, we're going to give about 10 to 15 seconds for each poll. So please go ahead and click on those polls. Just another moment or two. And great. And so we're going to go ahead and start the next poll, which will give us a sense of how long you've been practicing. A very simple poll, 0 to 5 years, 6 to 10 years, or more than 10 years. Great, so if you can please go forward and submit those polls. And as we do that, I'm gonna go ahead and transition into the next slide. For those of you who are new to Decipher, we provide genomic testing exclusively for prostate and bladder cancers, utilizing our CAP-accredited, CLIA-validated, and New York State certified clinical laboratory. Using this laboratory, we analyze biopsies and radical prostatectomy specimens. Specifically, we interrogate the tumor's whole transcriptome to provide the Decipher score. To date, we have processed over 90,000 prostate cancer samples. And as a company focused exclusively within urologic cancers, we have made a deep investment into the clinical development of our tests within prostate and bladder cancers. And as such, are involved with over 110 clinical trials or studies. And as it says in the top right corner, we have been designated by the state of California as an essential business and are open and accepting patient samples. The lab is running 6 days a week, so if you have any samples of interest, please send them along. We have 2 categories of Decipher tests. The Decipher Prostate Biopsy, which is intended for newly diagnosed patients and utilizes the needle core biopsy. For biopsy tests, we are covered by CMS and Medicare for NCCN risk indications. This includes very low risk, favorable intermediate risk, and unfavorable intermediate risk prostate cancer. Our biopsy test informs on active surveillance and definitive therapy strategies. Our Decipher Prostate RP is for decisions post-op, both to inform on early radiation therapy decisions, as well as decisions incorporating the use of a radiation therapy with or without ADT in the salvage clinical settings. Our products are in the NCCN guidelines for all the clinical indications I mentioned, including high-risk prostate cancer, which we are not yet covered by Medicare, but expect to gain coverage soon. Additionally, this year in the 2020 NCCN guidelines, our Decipher RP test was elevated to a recommend status. And to our knowledge, this is the first time a molecular diagnostic test has been recommended for localized prostate cancer in the NCCN guidelines. And we're excited about the adoption of the Decipher test within the standard of care. So a more quick poll until we get to the clinical cases. And this is a poll to see if you've used Decipher in any of these clinical settings. If you can just answer yes or no to this poll on your experience in utilizing Decipher. It looks like about 50-50 in terms of utilization. So we have some new users here. So this would be a very appropriate webinar for that. And we'll be focused on how we can use Decipher testing to inform therapy decisions in the favorable and unfavorable and intermediate risk indications. Decipher was trained and validated to predict which patients are at increased risk of an early metastatic event. The top row shows our training, where we utilized the Mayo Clinic tumor registry. We examined the tumor tissue from 639 patients who had been treated and followed for metastasis. Utilizing machine learning of 46,000 genes, we identified 22 genes across 7 cancer pathways, which, utilizing a Decipher algorithm, provides the Decipher score that ranges from 0 to 1.0, where patients who get a score of 0 to 0.45 are considered low risk. You see that in blue. From 0.45 to 0.6 with average or intermediate risk in yellow, and 0.6 to 1.0 are at the high genomic risk for an early metastatic event. The Decipher score has subsequently been validated as a continuous biomarker, meaning that at each point estimate increase, there's an increased risk of metastasis. It has been validated in dozens of cohorts composing of tens of thousands of patients. On the bottom row, you can see the Decipher process. So when we send a sample in, we start with the tumor biopsy or prostatectomy specimen, depending on the test. We then extract the RNA, prepare the cDNA, and hybridize to a whole transcriptome microarray. The output is a personalized Decipher risk score. Intermediate risk prostate cancer is obviously a unique intersection where nearly all the available therapeutic options for a localized prostate cancer patient can be applied to an individual patient, where patients may receive therapies ranging from minimally invasive active surveillance all the way through to radiation with a long course of ADT. With such a wide range of possible therapy, comes with it a very important decision of balancing oncologic control with the increased therapy toxicity in context of an individual patient's comorbidities and preference. I'll now hand it over to Dr. Tran and Dr. Ross to discuss the data generated to help inform therapy decisions for intermediate risk patients.
Okay, great. Thank you, Ryan. So just starting out with some background, I think all of us on the line are very familiar with the incredible impact that the risk stratification system that Dr. Anthony D'Amico devised a few decades back that incorporates T-stage Gleason score and initial PSA, and that is originally in its original form risk stratified patients into low risk, intermediate risk, and high risk. I can't say enough about the dramatic impact it's had on localized prostate cancer treatment, as it remains, essentially unchanged today. And that really is a testament to the great impact that risk stratification systems have in our prior and also current models for treatment making decisions. Speaking as a person who does research on biomarkers, predictive biomarkers are obviously the holy grail. So markers that would tell us exactly how to treat a patient with with a specific type of therapy. They are something that we're all striving for, but we're clearly not there yet, and risk stratification is going to be here for quite some time. So despite that advance of being able to break localized patients into low, intermediate, and high risk, we quickly realized that each of these buckets, particularly intermediate risk, was very heterogeneous, not only biologically, but important for this call clinically. And it was, again, building off of the great work of Dr. D'Amico, Zumsteg et al. From Memorial Sloan Kettering, were able to take their patients treated at Memorial and further risk stratify them based on the factors as shown on the screen into an unfavorable and favorable group. Again, utilizing some of these clinical and pathologic factors. For unfavorable, primary Gleason pattern 4, greater than 50% cores positive, or greater than 1 intermediate risk factor, and then favorable being primary Gleason pattern 3, less than 50% cores positive, and just 1 intermediate risk factor. The original paper cited there under the citation for number 1, but subsequently this risk stratification system has been validated in 2019 by Ali Berlin in a multi-institutional study, as noted in that second reference, of about 2,500 men. And then again, Zumsteg et al. Used the RTOG 9408 data set to look at a prospective clinical trial and again validate the dichotomization of intermediate risk into favorable and unfavorable subgroups. And subsequently, NCCN, the National Comprehensive Cancer Network, in their prostate cancer clinical trials guidelines have supported this refinement of intermediate risk into these two subgroups. Next slide, Ryan. So, what does that mean for treatment decisions based on the data, which is not perfect? NCCN has supported intensification of treatment for men with unfavorable intermediate risk disease when given with external beam radiation with the addition of androgen deprivation therapy or ADT, but not the patients in favorable. And questions pop up as posed on this slide is that, well, do all unfavorable intermediate risk patients require treatment intensification? And, how long should the course be? Perhaps should new agents be added for those that have really high risk of failure and death from the disease? And then for those in the favorable intermediate risk, who can be surveilled with active surveillance, since some of these patients are very much like low risk in their biology and clinical outcome. And then, of course, there are always within these groups going to be some outliers. Who are the favorable intermediate risk patients that actually have underlying more aggressive disease biology and require intensification with ADT? And again, the studies that I showed here, and particularly number 2 and 3, have supported this idea that at least these clinical factors can help us direct who should and should not get ADT when given with external beam. Next slide.
So thanks, Dr. Tran. Just to expand on that, so again, the dichotomy in intermediate risk is you have the unfavorable intermediate risk patients that most of us would agree need treatment, and then you have the favorable intermediate risk patients where we would say most of them may need treatment, but some of them may be candidates for active surveillance. And again, in all favorable intermediate risk, questions are about treatment intensification, whereas this carve out of favorable intermediate risk, you can think of, do we need to treat people at all, or can they be initially surveyed? As you all know, active surveillance is very safe and effective, certainly for men with very low risk localized prostate cancer, so small amounts of low grade disease. For low risk, there's also some evidence that it looks very favorable, and many of us in the field and also through clinical studies have been looking at favorable intermediate risk patients on surveillance and looking at it as a potentially appropriate initial management strategy, but there are some concerns. On the study on the bottom left there by Patel and colleagues, you can see that for men with intermediate risk 3 + 4 = 7 or Gleason grade group 2 prostate cancer, the risk of adverse pathologic features at prostatectomy are almost double those of men with Gleason grade group 1 3 + 3 = 6 disease alone, and that can lead to a decreased survival for men with with favorable intermediate risk disease. Next slide, Ryan. And you can also see in surveillance cohorts like this one from Ontario and others, where they put low risk men, and also they offered to favorable intermediate risk men surveillance as initial strategy, the metastasis-free survival was significantly worse for those who had intermediate risk disease. So it calls into question, who can we really safely follow with favorable intermediate risk disease? Are there men that are maybe older that we would not want to treat initially, or maybe younger men that want to preserve and not have too much morbidity that we may want to delay treatment on, that could be actually safe to follow without disease progression. Next slide, Ryan. And that's really the dilemma where we would say, beyond the NCCN risk stratifications that Dr. Tran talked about, can we go even further and perhaps use more prognostic markers to risk stratify men and see who's safe for surveillance and who may not be? Next slide. This is a schematic figure showing some work that Cooperberg and colleagues had done, where they looked at multiple prognostic signatures, including Decipher, and they looked across an active surveillance cohort and among men that had higher risk disease. And what they saw was that for people with favorable intermediate risk or low risk prostate cancer, some of them would have genomic features, so gene expression features that look very similar to men with higher risk prostate cancer. And perhaps those are the men that should be considered for definitive therapy and away from surveillance. Next slide. And this sort of gets to that point. If you look at people with low genomic scores that have Gleason grade group 2 or 1 disease, many of those men at prostatectomy will have excellent features and have organ confined disease, signs the disease might have been cured by your therapy. If you start to look at higher Decipher scores, they're not shown here, but men with Decipher scores in the high risk category above 0.45, almost 20% of those men will have unfavorable pathologic features at prostatectomy. So they'll have T3 disease, for example, at prostatectomy, and those would likely be the men that we would not want to follow. Next slide. And so kind of simply put, if you have someone with favorable intermediate risk disease, maybe Gleason 3 + 4 = 7, or maybe they've made it into the favorable intermediate risk category by having just an elevated PSA, and the other features look acceptable, and you're wondering if you can offer this person surveillance or not. If the genomic score comes back in the high risk range, so Decipher scores of 0.6 to 1, then those men should know that they have a 4 times greater likelihood of harboring adverse pathological features if they went to immediate treatment versus if they had scores in the intermediate or lower risk categories. And we'll see in our case examples as we go through shortly how we can go about making decisions in those men. But now I'll turn it over back to Dr. Tran to talk about decision-making in the unfavorable intermediate risk space.
Okay, great. Thank you, Dr. Ross. So we're very fortunate in the intermediate risk space with regards to radiation that we have really a relative wealth of level 1 data in the form of randomized controlled phase 3 trials looking at the addition of treatment intensification, in this case in the form of relatively short course hormones, 3 to 6 months, with external beam radiation. We're not going to go into any of the specifics of these 4 trials, but these 4 trials really form the basis by which we treat intermediate risk patients when you're thinking about the utilization of external beam radiation and whether to add in treatment intensification in the form of short course hormones. So really the take-home points from these 4 trials are that we see improvements in not only biochemical, free survival and cancer-specific survival, but overall survival. And the magnitude is relatively modest and improves somewhat if we look at in each of these trials, they were mixed bag. It was many of them were well before risk stratification schemes, modern day risk stratification schemes, I should say. But so if we look at just what we would call, DMICO or NCN intermediate risk classification patients, we see that in those patients, the addition of ADT intensification adds on as much as, could be as much as 10 to 15% of overall survival advantage. Next slide, Ryan, please. But fast forward now, as I was saying, in the modern day, many of those trials were performed before we had our current risk stratification schemes, and certainly before we were able to dichotomize intermediate risk into favorable and unfavorable. And so a dilemma really arises in the modern day, which is how do we take advantage of the fact that we know as a whole, intermediate risk patients benefit from ADT intensification when given with external beam radiation. How do we decide, again, these questions pop up, how do we decide which unfavorable intermediate risk patients really need hormones? Do they need short or long course, or trials we'll talk about in the future, even considering adding on and intensified ADT, such as with new androgen receptor blocking agents. And then again, so that we don't overtreat patients in the favorable intermediate, who can be, as Dr. Ross so nicely outlined who can be undergo active surveillance, and then of the patients who undergo treatment with radiation, external beam radiation, who are the ones that can really safely proceed with radiation alone. Next slide, Ryan. Next slide. So some specific data utilizing the Decipher test that Ryan had mentioned previously in this cohort of intermediate risk patients is presented here. This is a nice study out of Princess Margaret, led by Ollie Berlin, which looked at 121 patients from a prospective registry of intermediate risk patients who were treated with just dose escalated radiation. So 78 gray and 39 fractions, which is a very typical North American fractionation scheme prior to perhaps more broader utilization of hypofractionation, but nonetheless, something that I think many of us on the line are familiar with who deliver external beam radiation. And these patients were given only dose escalated conformal radiation alone. Decipher scores were obtained from tumor sampled in the diagnostic biopsies. And you can see there's a mix using just clinical parameters. There's a mix of patients of the favorable and unfavorable, about a 1/4, 3/4 split. And so this is a nice study because it builds on prior work that Decipher has been shown to be more able to risk stratify and prognosticate patients in a more superior fashion than clinical factors alone. And this study is specifically for intermediate risk patients. So the underlying hypothesis of this study is, can Decipher improve upon the risk stratification in intermediate risk patients better than the Zumsteg et al. Criteria, or the current stratification between favorable and unfavorable intermediate risk. Excuse me. Next slide, Ryan. So the data is as such using the endpoint of freedom from metastasis, which is a very relevant and strongly correlated endpoint to overall survival per a consortium known as ICECAP. So the plot on the left is a Kaplan-Meier looking at freedom from metastasis using just the clinical characteristics of that we showed previously, breaking patients up into favorable and unfavorable. And then the plot on the right is the same patients with their respective Decipher scores, and you can see, interestingly, that the clinical factors are not able to stratify the patients at all. The curves basically lie on top of each other for the ability of the risk stratification, favorable or unfavorable, to determine patients with their ability to be free of metastases. On the right, you can see quite clearly that low risk Decipher seem to do very well with just dose escalated radiation alone. And that's kind of consistent with the notion that these patients don't benefit from the addition of hormones at all. Next slide, Ryan. So looking at a different endpoint, biochemical free survival, we see that again on the left, the Kaplan-Meier plot of probability of freedom from biochemical failure, stratified by NCCN favorable or unfavorable intermediate risk stratification criteria. You see that those criteria are unable to distinguish the two patients groups. On the other hand, the plot in the middle shows that patients who come back with a high Decipher score have really poor control of their disease with dose escalated radiation alone. And then the table to the right is a more formal comparison of the performance between just the clinical criteria or Zumsteg criteria versus the Decipher score. And it shows superiority of Decipher over these clinical criteria using basically a method known as receiver operator curves. This is only shown for biochemical recurrence, but it's also, if you look in the paper, true for freedom from metastasis. So I think this is a very compelling data hypothesis generating from this single arms registry study. Next slide, Ryan. This data is very compelling, hypothesis generating, and that hypothesis is going to be tested. This is a schema for a recently approved NRG study with, all these NRG studies, as you guys know, many of you know, have these numbers. We recently have been pushing more to have names, and this study has a very nice name called Guidance. And the trial is recently approved by the NCI, and so the study PIs, Ollie Berlin and Neil Desai, are going to be writing up the protocol to have it activated shortly, and it's under the governance of our GU chair, Felix Fang. So this trial is going to answer really two questions. The first is, do patients using what's known as an integral biomarker design using Decipher, it's going to try to answer two questions. Do low risk Decipher intermediate risk patients benefit from short-term hormone therapy? One of the questions we posed earlier. And then the second is, do intermediate or high risk Decipher intermediate risk patients benefit from ADT intensification? And in this case, it'll be really intensified with darolutamide, which is one of these new AR blockers. So next slide. I think we're going to move into the case studies now.
Yeah, we now have a series of case studies for real-world patients treated by both Dr. Ross or Dr. Tran. And as part of the webinar, we will be polling the audience, as we mentioned, at the case presentation, and then again after the genomic results. So we want to see a kind of a before and after. So beyond providing feedback on the results to the audience, it is our goal to utilize this data for a manuscript led by Dr. Ross and Dr. Tran. Again, participation in the next polls are optional. However, by submitting an answer to the poll, you'll be consenting for the use of your answers in an aggregated and de-identified analysis. And as we go through the cases, if you have questions on the cases or how Dr. Ross or Dr. Tran would manage those cases, please submit those into the Q&A. All right, so let's begin. Here's our first of 5 patients. He is 64 years old. Biopsy yielded a 3+4 with 3 of 18 cores positive. 2 of those 3 cores were 3+4. The other was a 3+3. The largest involvement was 80% tumor with 20% pattern 4. The other 3+4 had 5% pattern 4. PSA is at 5.66 with a prostate volume of 23 cc's with a PIRADS 5. So this T1C tumor came back as favorable intermediate. So we're going to put up a poll right now. And so given this information and assuming an average or median fitness for the patient, if we can get that poll started, there we go. We would like to see what your primary therapy options is. And granted, we realize that you don't have all the patient information, so just think of your median 64-year-old patient. Would you consider active surveillance as your primary therapy strategy, focal or subtotal gland therapy, if a candidate by imaging, radical prostatectomy, radiation, so that'd be either external beam, brachy, or both, or radiation with ADT, either a short or long course. So we're getting the results. If you could please go ahead and submit those in. We wait another 5 or 10 seconds here. If you've not clicked on, please go ahead and click in. All right. So Dr. Ross, we'll keep that poll open a little bit longer. Dr. Ross, this is your patient. Without genomics, how did you approach this patient?
Yeah, so we talked to the man, as you summarized, he's a guy with favorable intermediate risk disease. And some of the things that we look at that are not related to genomics is, what's the percent pattern 4? His percent pattern 4 was 20% in a couple of the cores and minimal in the other cores. He did have PIRADS 4 lesions on his MRI, but the biopsy of those lesions that was targeted were negative for prostate cancer. And so his cancer that was found was MRI undetectable, but he still had this high PSA density with a PSA around 5.66 and a volume of his prostate around 23 grams. So we talked about a lot of options, a lot of standards around treatment with particularly radiation without hormonal therapy as a possible standard. We talked about radical prostatectomy as well. He was thinking about radiation or potentially focal therapy because all of his disease was on the right side. And we decided that, to help us with our decision making, we might want to get a Decipher to tell us, are we safe in thinking about some of these less aggressive modalities? How worrisome should we be about the pattern 4 that's there, and could he even consider surveillance? And so I think that you'll show the Decipher on the next slide.
Yeah.
So he came back.
Decipher, there it goes.
The Decipher came back low risk, and as Ryan wants to say, but I'm not letting him, is that puts him in a fairly favorable category, in the sense that, like, the chance of him having adverse pathologic features is like a person with Gleason grade group 1 disease only. And from the other studies looking at this, at overall this, the outcomes of men with Decipher low risk disease, that they likely can be followed on surveillance without sort of what we call escapes, or rapid progression on their surveillance to 4 + 3 = 7 disease or adverse pathologic features. Back to you, Ryan.
So I guess we're going to launch another poll. So with that Decipher low result and the clinical features we showed, does that change your therapy options? Would you more likely consider surveillance, or less intensive surgical or radiation strategy? If you can please click in. We got about another 5 or 10 seconds. And Dr. Ross, do you have any outcomes of this patient? I think you mentioned that he went on active surveillance.
I do. Once the polls close, I'll talk about it.
Okay.
So I discussed his Decipher risk with the gentleman, and he basically said, well, he's not really ready to undergo treatment. He met with a radiation oncologist, with myself, and we decided to put him on surveillance, and that we thought that was safe. We got a PSA 6 months after his biopsy. And even though PSA metrics can sometimes be unreliable, his PSA came down significantly. I just talked to him this morning, actually, and the PSA was 2.77, making him now have a good PSA density as well. My presumption was that probably the PIRADS4 lesions that popped up might have been related to some sort of focal inflammation or something, may have increased his PSA and triggered the biopsy, but his volume of disease is really a small amount of mostly favorable risk disease genomically and pathologically, and we decided to just go on with surveillance and go from there.
Great. So on to our second patient. He's 69 years old. Biopsy yielded a 3+4, 5 of 13 cores positive. 3 of those 5 cores had 3+4, the other 2, 3-3. The largest involvement was 30% tumor with 5% pattern 4. The other 2 3+4 cores had less than 5% pattern 4. PSA is 8.8 with a volume of 48 cc's. Has PIRADS 3, so the T1C tumor is coming back as favorable intermediate. So same poll question as last time. Assuming this is a median patient, obviously this patient's a little bit older. We can start that, launch that new poll. What would be your primary therapy strategy? So maybe a little bit less 3+4, or more lesions, but a little less involvement, but a little older patient. Does that change the way you approach this patient? Okay, a couple more seconds here. All right, Dr. Tran, I believe this is your patient without genomics. How did you approach this case?
Right, Ryan, and I'll add in a few more bits. So, a little bit older. He also had a history of peripheral arterial disease and had a right popliteal artery stent and left popliteal angioplasty. So I favored likely non-surgical approach. Obviously, he was seeing me, but something that made me hesitate about providing just external beam radiation alone was, and it's not caught in here, but he had a fairly brisk PSA velocity. So the PSA about 7 months earlier was only 6.8, And as Dr. Ross had mentioned, PSA kinetics and dynamics aren't super reliable, but nonetheless, that has been shown to be a poor prognostic factor. So for that reason, we had recommended that at first pass, he seemed like a decent candidate for external beam radiation alone because he was favorable intermediate risk. But I, of course, ordered a Decipher. I wanted a little bit additional information. So as shown here, he's high risk. And if we look at, the data as imperfect as it is for the group that were treated at PMH with just dose escalated radiation alone, which we would have done, those patients have pretty close to a 50% risk of biochemical failure at 5 years, which is considerably higher than we would expect for a favorable intermediate risk patient. So given that, we perhaps changed our treatment decision after that. And I think we can go to a poll now.
Yeah, go ahead and poll. So with the Decipher High and these clinical features, given what Dr. Tran said about the patient, what would be your preferred therapy option? So we'll give it about another 10 seconds here if you can go ahead and okay, we'll give it a couple more seconds. Great. So we're going to go on to our third case study. So this is our third patient.
I'm sorry, Rand. Let me just follow up with what we actually did for that patient. After we got the Decipher, we did have a discussion with the patient, and given that additional information, as well as the other clinical factors that we had talked about before, I thought it was in his best interest to consider a short course of hormone therapy with his external beam. For this particular patient, we ended up treating with stereotactic body radiation plus a short course of 4 months of ADT. I don't know if Ashley, if you, Dr. Ross, if you want to comment.
Yeah, I mean, I think this is a very important case in the sense that, like, actually, for this man, for me, if his Decipher came back as very low risk, he might have been sort of a borderline, but potentially someone that I would have followed on surveillance. PIRADS was 3 on the MRI. He's got comorbidities, this popliteal artery, all this stuff. And at most, I would have told him that, you should get radiation without hormones, and I would talk to him about some of the, metabolic effects and cardiac, risk factors that have to do with hormonal therapy. But once he comes back as a high-risk Decipher score, I'm very much in line with you, Dr. Tran, that even though it's a smaller series, the data that you already presented shows that these men will progress in their disease, particularly in terms of chance of metastasis. And I would have offered him exactly what you did, which is give him a short course of ADT with radiation to the prostate. So this is a case where really there could be a wide swing by the genomics, and I think that it gave a lot of clarity.
So third patient, also 69 years old, another 3+4. This is interesting because now he has 7 of 12 cores positive. PSA is at 9.27 with a volume of 46. T1C tumor is classified as unfavorable intermediate because over half his cores were positive. So given this information, we'll go ahead and launch the next poll. And assuming a median patient with these clinical features, what is the preferred therapy option? So the pathology is otherwise more like a favorable intermediate from a Gleason perspective because they have 7 cores positive is pushed into the unfavorable categorization. Okay, so if you can please vote on the poll. We can get a few more voting in, that would be great. All right, Dr. Ross, Dr. Tran, what's the thoughts on the management of this patient, how you'd approach someone who has a higher core involvement that pushes them up into the unfavorable and intermediate category?
Well, I think that most of us, again, you know, and let's say for argument's sake that his percent pattern for in these cores is like, you know, around 20%, 30% range. Most of us would lean towards treatment for this man. You know, he has 7 out of 12 cores positive. We're missing a little bit of clinical information, but let's say multiple of those cores were Gleason 3 + 4 = 7, grade group 2. Again, the PSA density is a little bit high. We would lean towards treatment. And if I was counseling the gentleman, I would tell him that, you know, radiation has less short-term side effects than surgery, equal oncologic benefit. But one big problem is that with unfavorable intermediate risk, you may need to have hormonal therapy as well. And, you know, what we could look at is perhaps getting increased information from the genomics, and then maybe that would help him decide if he can get radiation relatively safely, omitting hormonal therapy, or if he's in for radiation plus hormonal therapy. And if it's the latter, then he might be considering surgery more strongly. And so that's how I would sort of think about things.
Yeah, I agree with Dr. Ross. I mean, he's just barely unfavorable by the, unfavorable intermediate, excuse me, by these clinical characteristics. And if you look at the the strength by which each of these factors contribute to that, characterization of whether you're favorable or unfavorable, they each have their own distinct, um, hazard ratio or power, if you will, and number of cores, is not super high, as is PSA. A lot of it's driven just by the primary Gleason grouping. So yeah, in my mind, he's kind of a borderline case, and without any additional information, I would be, just like Dr. Ross said, be kind of pushing him more towards treatment. And then if he chose external beam radiation, it would be with a short course of hormones.
Okay. So the Decipher result came back at 0.32. So, given the data, let us know what your preferred therapy strategy would be. So Decipher low with this unfavorable intermediate, only pushed up by the core volume. What would be your preferred therapy given this lower Decipher risk patient? Give it another 10 seconds here. If you can go ahead and vote if you haven't done so. Great. Let's go ahead and close that poll. Dr. Tran, Dr. Ross, any thoughts on this patient?
Yeah, I'll start out if Dr. Ross doesn't mind. Given this data, I would be more willing to offer the patient, if he chose external beam, to offer it alone, and that's really exemplified, as we showed before, by the PMH data, Ollie Berlin's data, that patients who have a low risk Decipher have a very low chance of metastasis and if you look at where the bulk of the patients still sit, even out of 6 years, no patients have had an event. Now, there's caveats. It's a small study, very few events, but even the biochemical free survival is reasonably good with dose escalated radiation alone with these Decipher low patients. And we had kind of lumped dose escalated radiation into mostly external beam, but just for clarification, as before, the other patient I treated was with a hypofractionated regimen. And if a candidate for brachytherapy, I think that would be appropriate as well.
Yeah, I would echo these comments. And for the urologists in the sort of audience, I would say that for myself, for a long time, I was using these molecular prognostic tests like Decipher really to make decisions about surveillance or no surveillance. But after the Berlin data that Dr. Tran has kind of talked about and shown here, even though the guidance study isn't finished yet, I would say I routinely use it now in the intermediate risk categories to make this specific decision. Do we need treatment intensification or not? And it's most important in my older men like this gentleman, of which a lot of them will have at least one risk factor for coronary artery disease or some other type of heart disease, and I want to decide on the ADT or not. So I think that's what is one of the main thrusts of this webinar is This is a space where now, Decipher is sort of has data, is getting coverage, and there'll be more data coming, but this is exactly the choice that we're usually looking at. Decipher low risk, excellent outcomes. I think intensification can be omitted. Decipher high risk, even if the patient is just barely unfavorable intermediate, they may be doing a disservice by omitting or skimping on some of their therapy.
So move on to the next patient, another borderline patient, 65 years old, 3+4, 4 of 12 course positive. PSA is now 10.57, so just over the threshold of 10. Has a larger prostate volume, 68. Is classified as unfavorable intermediate because of the higher PSA. We'll do a quick poll here, assuming this is a median patient, a little bit younger than the last patient, but instead of course positive to make it unfavorable is now PSA. What would be your primary therapy strategy given the unfavorable intermediate risk? Okay, another 5 seconds for the polls. If you could please. Okay, that sounds good. So, Dr. Tran, I think this is your patient. Thoughts on the management of this patient?
Right. I mean, this is very similar to the previous patient where he's kind of this borderline unfavorable intermediate risk simply because of his PSA. And again, as mentioned previously, PSA kinetics and dynamics are they're not as they're not as reliable. So he was pretty healthy, and he expressed a desire to me that he wanted to try to avoid ADT. So that was the exact reason why we ordered the Decipher in his case, to give us some additional information.
Great. And his result came back actually very, very low, 0.12, and kind of follows similar to the last patient. So if we can go ahead and put the next poll up, which is given this Decipher low and the clinical features, what would be your preferred therapy option? Okay, a couple more seconds here. Please submit your poll. Okay, comments, thoughts on the results here?
Yeah, I mean, one point that, and I know Dr. Ross can add to this, is that the Decipher score, the way that it's generated, it really is a continuous prognostic factor. So going from 0 to 1. So even though it's broken up into these what we call locked subsets, the score itself really is telling, it says more than just whether the patients are low, intermediate, or high. And so even more so, I felt very comfortable saying, telling the patient that he could proceed in this case with just external beam alone, dose escalate external beam alone. So I don't know if Dr. Ross has anything to add to that.
Yeah, I completely agree.
So our last patient, another interesting patient, so 7 years old, a little bit older. A biopsy was 3+4, 2 of 12 course positive. Both course had 10% involvement. Very high PSA this time, 18.71, and also a very large prostate, 103. T1C is now unfavorable intermediate because of the PSA over 10. Put the last poll up here, if you can assume the median patient for this patient, for these clinical features in a 7-year-old patient. What is your preferred therapy strategy on this particular patient? All right, another 5 seconds for this poll. Great. Dr. Ross, Dr. Tran, thoughts on the management of this case, and given a large prostate volume like this, PSA over 10, a bit older?
He definitely has. I mean, there's definitely a couple things that are giving concern. The you know, the PSA is high, his gland is large, but the PSA density is still a little bit high. He does have a little bit of Gleason grade group 2, 3, 4, 7, and the PIRADS is 5. You worry a little bit about, you know, could the disease have been undersampled, or, you know, is it just that the is the disease like indolent in nature? I think I would really need genomics to help me make that decision, so we can see what the genomics showed. And
So it came
so,
back very high, 0.81.
yeah, and so let's see what the audience thinks.
If we go up the last poll. Okay, given the high Decipher score, 0.81, looks like about a 46% chance of high-grade disease and considerable risk of mets. Okay, let's go ahead and close that out.
My thoughts with this high-risk Decipher score, I mean, he obviously needs treatment, and actually, I would say that there's 2 types of treatment he could get. One would be hormonal therapy with radiation, and I would also talk to him about prostatectomy. You know, even though he's a little bit older, at 70, if he has significant lower urinary tract symptoms, I would tell him that, look, the Decipher genomic risk is high risk. You know, radical prostatectomy is still fairly safe, and if you have LUTs, let's go in that direction. I would then tell him, if you do radiation, I'd strongly advise him to combine it with hormonal therapy. My one question to Dr. Tran is, again, this guy is a 347 PSA over 10, almost 20 case. With this high Decipher risk, would you modulate, you know, your length of hormonal therapy, or would you just go with 4 months if you offered him, or 46 months if you offered him hormonal therapy?
Well, so all those studies that we had mentioned previously were between 3 to 6 months, and certainly there's no data to suggest, or very little data to suggest that there is a preferred amount. But absolutely, I mean, there's some retrospective studies to show that, you know, being on ADT longer seems to improve certain outcomes. And really the standard of care in North America is between 4 and 6. So I would be leaning more towards, if he chose external beam radiation or radiation, to add on 6 months of hormones, and just start with that.
Yeah, I think when guidance, I think that arm of guidance, although it seems very aggressive with the addition of darolutamide, that arm actually is going to be very informative, and that would be more for the not this patient, but the 4 + 3 = 7 patient in multiple cores with like a higher PSA. You know, trying to tease out whether those guys with high risk Decipher need that additional intensification. I think it's going to be a very informative metric.
I agree.
So this is our last patient. Do you have any other comments, Dr. Tran?
Oh, I was just going to say, I mean, there have been cases, you know, which is what Dr. Ross is pointing out, where you know, they have, their factors are such that they really feel more like a high risk patient, and so you struggle with, oh, should this patient be on longer course of hormone? Right now, with the data we have, with, you know, using this strict interpretation of the data we have, you know, 6 months is probably the longest that would be recommended, but I don't think it would be unreasonable for somebody, you know, to put this patient on longer course hormones.
Okay. So since this is our last patient, if you can please type any questions you may have while we are typing those in. Dr. Tran, maybe if you want to go over the take-homes from the webinar, and then we'll go into the Q&A.
Sure. Well, hopefully, you know, Dr. Ross and I have, with Ryan's help, been able to convince you folks that intermediate risk prostate cancer is a very heterogeneous group with different biologies and different clinical patient outcomes. And, you know, just like all of medicine, it requires a nuanced approach towards decision-making for therapy. I believe Dr. Ross really do think that Decipher improves upon our ability to estimate the patient's risk of biochemical failure, as we showed before, but really more important endpoints of metastasis, and metastasis has been associated with overall survival. The Decipher risk score can improve our ability to determine eligibility for things such as active surveillance in these patients who have favorable intermediate risk disease. You know, as important it is to not undertreat somebody, you know, over treatment obviously is a huge issue, and that's been shown to us by the whole active surveillance movement. And then lastly, Decipher risk score can improve our ability to make decisions regarding the addition of ADT, and then with the help of guidance, intensified ADT in these intermediate risk patients, as Dr. Ross had mentioned previously.
Great. So a few questions that have come in. So, you know, this is, I think, one that we get a fair amount. I'd love to get your feedback on. How do you take an intermediate risk score? So we've shown a fair amount of low risk deciphers and high risk deciphers. You know, given, you know, the typical 3-4 patient, what's your thoughts when you get an intermediate or average score back on Decipher?
So for me, if it's someone where I was trying to consider treatment or surveillance, even though the data somewhat suggests that the intermediate risk Decipher score guy would be safe, I usually dissuade them from surveillance when I get an intermediate risk score, like a 0.5, you know, unless there's other extenuating circumstances, because I just don't think we have robust enough data. Similarly, you know, even though there really was in the Berlin series, there really was a sharp cutoff between going to high risk and everybody else. When I get those intermediate risk patients, you know, I basically maybe call that like an uninformative score, and I tell the patient that I would lean more towards giving you ADT because there's just more established data. So for the unfavorable intermediate risk gentlemen, there's just more robust data that on a population basis they do better with the ADT. So I sort of follow sort of more of my standard things and say that it's somewhat quote unquote uninformative. I will echo Dr. Tran's point that the Decipher score is a continuous variable and should be treated that way. And so there's a difference with someone being maybe 0.46 and someone being 0.59. And so it's, you know, not just this or that, but I tend to really play more at the high and low risk Decipher score categories in terms of where I really will shift my decision making. Luckily, not many patients seem to really fall into that intermediate risk category right now.
Yeah, no,
So
I wouldn't add too much from what Dr. Ross said. And that's basically how I utilize it as well. Is if they're intermediate risk, then I kind of just stick to you know, the more traditional Zumsteg classification of what I was, you know, what that would direct me to do.
okay. And then Dr. Tran, this one's for you. Given the guidance trial and I think the nature of trials in you know, localized prostate cancer, that they take years to get to MFS endpoints, and we have these data gaps. How do you anticipate using genomic tests like Decipher to inform on ADT while you're waiting the prospective data?
Well, yes. You know, when you really think about it, there's been really no prospective validation of the risk stratification system we currently use, right? And even of the bifurcation of intermediate risk disease. I mean, that's really what the guidance trial is partly trying to do. You know, you have to take into account the strength and the level of the data. And although it's relatively early, smaller subsets, I think the Decipher test has had, among the genomic tests, has had the most validation. And I have been using it in these instances as per the cases that we've shared with everyone. So absolutely, you know, there's always going to be early and late adopters to any technology. And for this one, I guess generally, I guess I would consider myself an early adopter of this technology, but you know, that's how I would justify it.
You know, I would echo that. I mean, the ability of Decipher to be an independent prognostic indicator of disease outcomes, you know, that's been kind of validated and tested either, you know, retrospectively or in some cases prospectively in like tens of thousands of patients in the retrospective analyses, ones with really hard outcomes like metastasis or death. So, you know, right now, even though it has maybe still needs validation in the specific for the specific question of like treatment intensification with or without ADT, or with, Daro in another arm of that trial, I think that it's safe to use it as an additional prognostic indicator, the same way that I was mentioning I would use percent pattern 4 or the number of cores involved by Gleason grade group 3 disease or 2 disease to make these decisions. So just like Dr. Tran said, lots of things that we'd use every day have not been validated in any specific context, but like the bones of what those are, the Gleason score predicts poor outcomes. That's kind of been indirectly validated in many different ways over time. So, and the big change, and the reason this is a timely seminar, is it hasn't been that long where we've been able to, where the payers have supported us being able to order Decipher on these intermediate risk patients. So before it was a lot of research only. Now we have the opportunity to do that and get that information. And at least in my practice, I haven't, and maybe Ryan can speak to this, I haven't had to have that threshold of fighting to try to get a genomic score back for someone with unfavorable intermediate risk disease. It's just, if I want it, I order it and I get back the values, and it's not much of a hassle.
Yeah, exactly.
So
I echo that. I was just going to add, I mean, that's exactly how I see it as well. And that, if somebody said to you, if you weren't able to get percent, positive cores, but they said, oh yeah, you can get it. Well, wouldn't you want that information? Yes, you would want that information.
Great response. So we have a lot of other questions, but we're out of time. So what we're going to do is we're going to make sure each of these questions are answered. So if you asked a question, we'll respond back either ourselves or we'll ping Dr. Ross and Dr. Tran and get you a response back. But first, want to thank you, Dr. Ross and Dr. Tran, both for your contributions into presenting this webinar, and thank the audience as well too for joining. We will go ahead and send a link to the webinar in case there are sections that you want to miss or want to review. So you'll get that link in the email, and please look forward to a future webinar from us shortly. So thank you both again for your time, and looking forward to the next time.
Thanks, Ryan, and thank you, Dr. Tran. Thanks everyone who attended.
Thank you.